Our next session is around an issue of huge public importance, health care and access to it in Wisconsin. Specifically, this session will look at the ways in which accessing health care varies based on where one lives, whether a person is impoverished or not, or on their racial and ethnic identity. And of course, that's a concern that should be of interest to us all. We will also explore solutions and ideas for how we can leverage policy to develop programs and services to improve overall health and eliminate inequalities in outcomes. So our title for this session is Why Health Equity Matters in Wisconsin. Our session sponsor for this conversation is UW Health, the Carbone Cancer Center, which joined us this year as a major IDFS sponsor for the first time, and we're really proud to have that association. You probably know Wisconsin has been historically recognized as a leader in healthcare, consistently ranking as one of the top states in the country in health outcomes. Yet a parallel legacy of health equities persists. Our outstanding panel will explore dimensions of the problem and solutions for pursuing health equity for all. Our moderator today is Dr. Michelle Robinson. Dr. Robinson is the Chief Programs and Partnerships Officer for the Foundation of Black Women's Wellness, a state-based nonprofit working to eliminate health disparities and other barriers impacting the lives of Black women and their families. The organization works to accomplish this through programs that energize, mobilize, and support Black women to transform their health and their lives. Our panelists are Amanda Dreyer, who's the Deputy Medicaid Director at the Wisconsin Department of Health Services. She supports the teams that run health care and nutrition programs for the people of Wisconsin. Next is Dr. Tiffany Green, an Associate Professor in the Departments of Population Health Sciences and Obstetrics and Gynecology at UW-Madison. She is UW's Chair in Women's Health and Health Equity Research. As an economist and a population health scientist, her mission is to understand causes and consequences of racial and ethnic disparities in reproductive health. Finally, we have Dr. Ken Loving, who is CEO of Access Community Health here in Madison. Dr. Loving directs and leads the organization's mission of creating a healthier and more equitable community, along with ensuring that Access provides high-quality healthcare services. So with that, please give a warm welcome to this panel.
Good afternoon, everyone. To our esteemed panelists and to each person joining us here live and those who will be joining us in the rewatch virtually. As Paul shared, I am Dr. Michelle Robinson and I serve as the Chief Programs and Partnerships Officer for the Foundation for Black Women's Wellness. And prior to stepping into this current role, I had the honor of serving as the inaugural Director of the Office of Health Equity for the Wisconsin Department of Health Services, and also serving as the Vice Chair for the Governor's Health Equity Council and being the primary author of the Council's 2023 report titled Building a Better Wisconsin, Investing in the Health and Well-Being of Wisconsinites. So on behalf of my CEO and founder, Lisa Payton, who was unable to be here today, I want to just welcome you all to this Ideas Fest session, and thank you all for taking the time to engage with us as we discuss our collective health, a topic that's not only critically important, but is a topic that's existential. Since June of 2012, the Foundation has been working to build a generation of empowered, well Black women through our efforts to eliminate health disparities and other barriers impacting the lives of Black women and girls through energizing, mobilizing, advocacy, and powerful partnerships. At a micro level, we support Black women and families individually and collectively through health and wellness and preventative health education and programming that supports them in building healthier lifestyles to prevent and or better manage chronic illness and disease. We also, at a macro level, support Black women and families by working to drive systems level and policy changes, which support the advancing of health equity to transform environments into ones which protect the well-being of Black women, their babies, their families, alongside all other communities experiencing disparate poor health more broadly. So, as the title of this session is, let's start by talking about what is health equity. And when you go to the Googles, there are lots of definitions you will find. But one of the things that connect all of these definitions is that they tend to speak to the underlying social, economic, environmental, political, cultural contexts that we all exist in, which shape our health for better or for worse. And I must acknowledge that this is a shift from how most of us talk about health. Most of us have been taught that it is really only about our individual and personal behaviors that matter for influencing and shaping our health outcomes. But the problem with this framing is this: our individual choices and decisions alone excludes all of the other factors outside of our personal behaviors that also shape our health. Things such as polluted waters, housing insecurity, or the lack of family-supporting jobs. Health-shaping factors such as these are matters of social and public policy. And in order to address them, we will need policies that promote the creation of the kinds of conditions that support our ability to avoid sickness and disease caused by exposure to conditions and environments that otherwise influence them. And yes, this all matters. Morally and ethically, this matters because we are causing avoidable suffering and losing lives prematurely, things that we can prevent. And we are all paying the price of this social arrangement, whether it is through the loss of human potential that results from premature death, the collective grief, pain, and anguish it facilitates, or the actual financial costs that we are all being burdened by. In fact, in 2020, for every 100,000 Wisconsinites, there was an estimated 7,658 years of potential life loss in our state. Years of potential life loss is a public health metric that describes and quantifies premature death, which is defined as death that happens before 75 years old. In 2020, the average life expectancy in the US was 77 years of age. So when we disaggregate this measure by dimensions such as race and ethnicity, a different picture immediately appears, revealing that there is a great deal of population level variation. In Wisconsin, across racial and ethnic groups, the years of potential life loss varied from a low of 3,602 years per 100,000 in the population for Asian Americans in Wisconsin to a high of 14,721 years per 100,000 in the population for Black Wisconsinites. Health inequity can even be translated to a monetary cost. The health inequity tax we all pay for maintaining the conditions and arrangements facilitating this current distribution of population health and health disparities in our state and in our nation is significant. A 2023 study published in the Journal of the American Medical Association found that in 2018, the economic burden of health inequities for racial and ethnic minoritized populations was somewhere between $421 billion and $451 billion. That's about 2% of our GDP and cost us each about $1,377 per person. When we look at this based on education, for health inequities for adults without a 4-year college degree, that amount goes up to $940 billion to $978 billion, which is about 5% gross domestic product, or at a cost of $2,988 per person. So, to ground today's conversation, I want to end by sharing my preferred definition for health equity, which comes from the Robert Wood Johnson Foundation, who simply define health equity as everyone has a fair and just opportunity to be as healthy as possible. This definition speaks to the need to remove obstacles to health, such as poverty, discrimination, and their consequences, including powerlessness, lack of access to good jobs with fair pay, quality education and housing, safe environments, and health care. As such, health equity requires that we reduce and ultimately eliminate disparities in health and the social determinants of health adversely impacting our neighbors, our peers, and our friends. Thus, health equity represents both a means and an end, one that is transformative and inherently rooted in justness. So, I now invite these wonderful individuals on the stage to join me in engaging in a discussion where we will dig deeper in on this issue, sharing what we know and what we're doing here in Wisconsin to respond to this addressable context, as well as what we should or could be doing. And Dr. Green, we're going to start with you. So, I've shared a little bit about the context of health equity in our state, but can you help paint the context a little bit more? Who is being impacted? In what ways? Can you talk about it a little bit across race and ethnicity, economics, or place, or gender? And also, can you touch on why we cannot reduce health equity as a matter of simply about poverty?
Thank you so much, Dr. Robinson, and thank you so much to all of you for being here today. I'll level set by saying that I care about health equity because I'm selfish. And the reason I say that is because, as I always say when I talk, I grew up watching the Jetsons. Did anybody grow up watching that? And you see how everybody was flying around in the car? And because of these inequities, we can't have nice things. And I am very committed to making sure we have these things, but we don't live in a Wisconsin where everyone is free to reach their highest potential, and thus we will be sitting in traffic on the highway for forever if we don't do something about it. Joking, but not joking. So what does that mean? It means that where we work, where we live, where we play, where we get health care, where we worship or not worship, shapes our entire lives in this state, just as it does in the rest of the country. Let me give you a little bit of data from the Wisconsin Population Health Institute. One thing we can talk about is education. So educated Wisconsinites, we might imagine, have much better health outcomes than those who are not educated. Here's a great example. Among Wisconsinites with a college education, there are 568 deaths per 100,000, right? But for those without a high school education, over 1,600 deaths per 100,000. That means that if you don't have an education, you're far more likely to die relative to those people that have a college education. And we can say the same thing for race. When we look at race in Wisconsin, the lowest mortality is among Hispanic Wisconsinites that have about 477 deaths per 100,000. For Black Wisconsinites, it's over 1,000. Right? And this is not just at the end of life, it's at the beginning. Many of you have heard about Wisconsin's infant mortality. Is anybody familiar? Well, we have relatively low rates of infant mortality in Wisconsin if you look at the averages, right? But when we look across race, we know that infant mortality rates are about 3 times as high among Black birthing people relative to white birthing people. And all this is to say that across all parts of our lives, when it comes to birth, to death, to being able to survive and thrive, education, rurality, race, all of those things play a role in our ability to reach our highest potential. And I don't know about you, but I'm not satisfied until we all have a flying car, unless you can't drive, right?
Thank you. Dr. Loving, turning to you. You lead a federally qualified health center, something we refer to as a FQHC. So you are seeing a lot of what Dr. Green is describing on the ground. Can you share a little bit about what you all are experiencing as it relates to encountering patients and clients navigating unmet social needs that's impacting their health?
Certainly, and I want to just thank everyone for being here today. I feel really honored to be up here on stage with my fellow panelists today. A federally qualified healthcare center. Some of you might have heard of what we do. Just to break it down, typically I start by talking about being a place where people can come get care that is high quality, primary health care that is high quality and also affordable, and primarily for people that face barriers in other areas where they could get care but are unable to do so. So we also strive to be clinics of choice in the community and not clinics of last resort, because we want to make sure that our patients understand that they are valued and that they should be getting health care just like everybody else is in their communities. Community health centers are designed to eliminate barriers to care, and there are a number of different barriers that we could talk about today, but I'll just focus on a couple of the most difficult ones that we see. And it starts with financial barriers, typically. And when you think about how our system is structured, for people that don't have health insurance, it is very difficult to be healthy through the healthcare system. And so at Access, we have a sliding fee scale for people who are uninsured, who make up 15 to 20% of our patient population, so that they pay based on their household income. And they can get that care, and it can be affordable at the same time for them. Another major issue that I just think many people don't even think twice about is transportation. And many of the people we care for really struggle with that in all aspects of their lives. Community health centers are designed to be located in the communities that we serve, and that is certainly true for Access Community Health Centers where I work. The other barrier that we see on a daily basis, about a third of our patients at the health center speak Spanish as their primary language. So language is clearly a barrier as well for people, and what we try to do to alleviate that barrier is we have employed interpreters at our clinics. We also contract with other interpreters to come in and help care for our patients. We can use a language line, but that's typically not the most ideal way to do this. Last year, we provided translation services for over 35 different languages in our clinics, and so this is an important thing to consider. And I could go on, but I'll get to what I think is the primary barrier for people, and that is trust. People have oftentimes had very negative experiences in the healthcare realm, and that impacts how they're able to access care and whether they're willing to access care. And when you think about the institutions in our society in general, who they're built for, they're not really built for the patients that we see at the health center. And so what we try to do there is make sure that we have services that make them feel like it's built for them. And that's what we've worked on in the last 25 years at Access. Part of the way that we do that is, we have a unique patient population for sure. 90% of our patients are at 200% of the federal poverty level or below, and the majority of those are under 100% of the FPL. And just a reminder, for a family of 3, the FPL is about $30,000 a year. So those are the people we serve, and we've created a model for them that we think serves them fairly effectively. Medical services are sort of the first thing that we built, but community health centers across the country need to be able to provide dental services as well, and behavioral health services and pharmacy services. So the way that works in our community health center is we have about 30,000 patients at Access. Almost half of those people get dental services. So it's a large practice, one of the largest practices in the county. And we also have the integrated behavioral health for people. And that integrated behavioral health means that psychologists or social workers are working alongside medical providers in the clinic to make sure that if a behavioral or mental health need arises, they can see the patient in the moment at that medical appointment, and then provide ongoing services for them over the longer term. And I want to just say a couple words about the history of health centers, because I think it's important to see the evolution of health centers across the country. The health centers started in 1971. They were an outgrowth of the War on Poverty. The first ones, there was one in rural Mississippi and one in urban Massachusetts near Boston. And since that time in 1971, there has been, for the most part, strong bipartisan support for community health centers across the country. And we're at a point right now where community health centers, the 1,400 community health centers across the country that represent about 5,000 clinics, care for over 30 million people in our country. And so that's, 1 in 12 people, more or less, that we're caring for. So the program's always been held up as sort of an ideal governmental program that really benefits the people that we serve.
Well, thank you, Dr. Loving. That $30,000 statistic is really important. $30,000 doesn't go very far nowadays.
Yeah.
All right, Amanda, let's pivot to you. So you represent the state's Medicaid program, and Medicaid is a powerful and very complex program, but we know that it can be leveraged in different ways to address related social-related health needs or social determinants. So what are some of the ways in which different states are leveraging Medicaid innovatively to do this, and what is Wisconsin specifically doing?
Yeah, that's a great question. First, thank you again for having me. Thank you all for being here. This is an incredible panel, and really proud to be part of the team that is working to address health equity in the whole variety of ways. We could talk about that today. I think we could probably spend a million years, and happy to do it. Medicaid is an incredibly large and complex program, ultimately the funding arm of healthcare services delivered to individuals. There's certainly a number of other ways we could talk about Medicaid and the ways that we spend those funds. Part of that today is about what I'm going to call health-related social needs, or the social determinants of health. There's a small differentiation in there that is maybe more relevant and potentially a vehicle for Medicaid programs like ours here in Wisconsin, as well as across the country, for how we can effectively deliver those dollars to help address, one, potentially prevent health needs, but then also address them as they arise. The Medicaid program is a shared program. We collaborate as a state with the federal government to get the authority and the approvals we need to be able to spend that money. So without those approvals, there's really nowhere we're going. There's no gas for a flying vehicle, if you will, or electricity maybe. And so as we do that negotiation, part of our job is to help articulate and describe what we're experiencing here in Wisconsin and how Medicaid delivers to help address the needs that we have, the realities that we have, which have been so eloquently described already. What we are seeing is encouraging, honestly. Governments can be really slow. We are here to raise the bar, build that foundation for innovation to happen. But in 2021, the Centers for Medicaid Services and Medicare Services issued a letter to all states and territories to describe how state Medicaid programs can begin to address health-related social needs. And there's been a couple of key programmatic focuses there, and it's tied to evidence-based delivery mechanisms, which is not surprising in a healthcare setting. One of those is nutrition. Another one of those is housing. We have about 5 states right now who there are 2 different mechanisms by which we can go about delivering this money. One of them is through a waiver where CMS says, yeah, we're going to waive some of these requirements so you can do some of this cool, innovative stuff. Another way is through what we call in lieu of services, which is where we redirect money we already have to deliver on things like nutrition and housing instead of other more targeted treatments or interventions later, with the expectation that our outcomes are better as a result and that the cost of those things is neutral or improved. So with those 2 focuses, there are 5 states who are either in a pending status or currently approved with CMS to do some really robust health-related social needs programming. I'm Very excited about places like New York and Washington, Oregon, have really major health-related social needs waivers with CMS. Here in Wisconsin, we've got a bit more targeted focus at the moment, but big hopes and dreams. Really proud that shortly after we received that letter in 2021, Wisconsin was the first state to provide some housing, health-related social needs support for kids through our CHIP program. That includes some really meaningful things, right? Dollars to transition out of a shelter or a motel or a hotel. That could be rent assistance for that security deposit, or getting your utilities paid, or furnishing that home when you first move into it. It helps support kids and families, pregnant people who are at or less than 200% of the federal poverty level, and also either experiencing homelessness, at risk of homelessness, or fleeing a domestic violence situation. So pretty powerful, pretty targeted, but exciting for what we can be able to do next, which we hope and are so close to being able to provide for adults. And then another thing that we are working on in the nutrition space that we're excited to get started here in 2025 is a more direct, actionable, in lieu of service for medically tailored meals. So we work with a dietitian to address the foods and nutrition supports you need to help better manage your health condition, let's say hypertension or high blood pressure. And we are working with our insurance partners to be able to deliver that to a specific set of patients who might qualify, with the hope that we can demonstrate really effective outcomes and grow from there. So 2 small steps in what is hopefully a better future.
Thank you, Amanda. That actually sets the stage quite nicely for another question to you, Dr. Green. So you are an economist who studies health and policy. What are some of the program and policy interventions that you are hearing and seeing that are either showing or hold promise to reduce or eliminate health disparities and improve overall population health, whether that's in the maternal child health space or in chronic disease?
I feel the need to clarify that I am an economist who does not balance her checkbook, so I'm not going to do any cost-benefit analyses here. That said, there are some great and promising programs that I think will help to move the needle. I'm so happy that you talked about housing and nutrition supports. When we talk about the drivers of preterm birth, low birth weight, infant mortality, it's really not just in the healthcare system, it's the social needs that people have. How do you have healthy pregnancies, healthy births, when you don't have stable housing? And so one of the things that I think is going to be very promising and that we have to be patient for is the impacts of these housing interventions and these nutrition interventions. Making sure that people have their basic needs met should be obvious, but I think that's going to be very important. Those would be my favorite things. There's also been a very big rush of income support programs. There is a program going on in Milwaukee trying to pilot giving pregnant people income. There's also the Abundant Birth Project in California that's being targeted at Black pregnant and birthing people to see if giving people income, surprise, surprise, if it's going to help their health and well-being. So I think those 3 things are going to be to receive a lot of attention in the coming years. So too long, don't read. Make sure people have their basic needs met, because when you have those basic needs met, they can focus on the other things that help get us to the next level. And I can't imagine that Wisconsin will be any different.
Wonderful. All right. Continuing on this trend of thinking about programs and policy solutions, Dr. Loving, you shared a little bit about what Access is doing, and I would love to hear you go a little bit deeper around how you all are addressing some of these gaps in access to social needs. One of the things I guess I'll put my finger on the scale and say maybe you would like to speak a little bit about a local initiative, the Saving Our Babies program, that is working in this space of perinatal disparities.
Yes, thank you. I would love to talk about that, because this is a unique collaboration that we've been working on for the past 6 or 7 years, primarily in Dane County. And just to describe the partners involved, it includes all of the health systems in our community, the Foundation for Black Women's Wellness, Equity by Design, the Madison School District, the Public Health of Madison and Dane County, and the United Way of Dane County. So I just want you to think about that for a moment, getting all those people around the table, and we're talking about leaders of all of these organizations that sit down at least every other month, and a staff team that is meeting every week to focus specifically on the Black infant mortality disparity in our community and in many places in our country. This is something that doesn't happen very often, and it is happening in our community. And what we're seeing is we're seeing progress, and progress that we'll be able to report on more in the future. And the way that that's happening is sort of looking at the care delivery system and understanding that what people are getting when they come to the healthcare providers is not sufficient. So building out services that include doulas, who are birth assistants that are experts in prenatal and perinatal care, to pair with Black birthing people, and also community health workers that can really make a difference in the lives of the families that are, in the midst of having a baby, which is obviously a long and complicated process. So this collaboration is something that we have been really successful at to this point, and I think we're just sort of scratching the surface at where we could go. When we make a difference that we can document clearly, we're going to have an enormous amount of attention on our community, and people are going to want to understand how we were able to accomplish this, and they're going to want to repeat it in their communities.
Before I move on, I want to just check in with you, Dr. Green, if you wanted to share anything as another partner on the Saving Our Babies work, if you wanted to add anything to Dr. Loving's remarks.
Yes, of course. I had the privilege of serving as the inaugural co-chair of the Black Maternal and Child Health Alliance for Dane County and work along with Dr. Loving and some of the other executives. I want to just really reinforce how innovative this program is. I have the privilege of being part of the team to evaluate it. And again, they're matching people with doulas. They're matching people with the social supports that I'm talking about, housing, food insecurity, unemployment. All those things matter when it comes to making families healthy and whole. And I want to reinforce something else that I think also has not been emphasized here, and you did a great job, obviously, Dr. Loving, but it's so innovative because people are getting postpartum supports. A lot of times when we talk about things that go left, when it comes to birth, it's really after the hospital, having nobody come in and check on you and your families. And these birthing folks and their families are having support from community health workers and doulas and post-birth. So I think this will be, I think, an important example of how you can have a multi-sectorial partnership to help improve the health and well-being of our community, because I firmly believe that when you invest in Black people, when Black people do well, everybody is going to benefit. So I'm really thrilled and honored to have been a part and ongoing part of this program.
Thank you. All right, Amanda, we'll come to you now. So, whoops, let me take that off. So, we've talked a little bit already about some of the ways in which Medicaid is specifically trying to address health-related social needs. But also, Medicaid is also kind of engaging with this broader conversation about the importance of partnerships and community at the table. Can you share a little bit about some of the things that you all are doing, whether it's regarding councils or community groups that you all are organizing to really start to think about ways in which to bring voice into addressing health disparities in the state?
Yeah, this is shifting in really exciting ways too. Maybe tagging on to the good work that's already happening, it connects directly back to the governor's task force on the healthcare workforce, which identified things that aren't going to be surprising given the work that's already ahead, the innovations already happening in the communities, and is asking for things like doulas and midwives and community health workers so that we have the workforce we need to be able to deliver this care, and how can the government help support those things. That was also a large, diverse group of leaders across the state to help us get to that framing of the problem, the solutions for the problem. One of the initiatives I'm really excited about inside of the Medicaid program for these collaborations and amplifying new voices, critical voices, and is one of the things that I learned in being able to work with community health centers in the past is the criticality of hearing from the patient about their experience, about their needs, listening to them, hearing them, understanding them, and then wrapping around them to address those needs. And we are doing that by improving and adding those member voices, we call them in Medicaid, to our advisory committees. So we have a Medicaid advisory committee, which includes a lot of really dedicated, smart, capable leaders throughout the state. We've got community health center representation, we've got a health equity expert, behavioral health providers, case managers. It's a group of about 20 people right now, and we will add in members who are using our Medicaid services. And then we will also stand up a brand new beneficiary advisory council, which really means a group of patients, a group of members who are currently using or have recently had Medicaid services to help share their stories, their recommendations to help guide the future of how our programs work. Really excited about that. And then we continue to learn and amplify as much as what happens in the community as we can, and then funnel our funding to amplify, embed, systematize those innovations. So the Saving Our Babies initiative being one of those very cool, important things, but certainly looking to do more in just the day-to-day good work that is happening in healthcare.
So Dr. Love, I'm going to pivot to you this time. So you shared a little bit about this, but maybe let's spend a little bit of time digging in a bit more, because I think that the FQHC model offers us an important framework for understanding what care might need to look like in the modern world. So can you share a little bit more about what makes FQHCs different from healthcare environments that are not FQHCs? And what might other environments, healthcare environments, learn from you all about not how to simply address the clinical needs that present, but the broader social needs of their patients?
Sure. I think one of the things that we value most at the health center and our patients really respond to is the idea of integrated care and having a variety of services put together, because the way the healthcare system sort of grew up is there's a lot of segmentation. And of course, you know, your oral health plays into your overall health. And so, but oftentimes dental and medical are really split apart. And that's the same with behavioral and mental health services as well. And so being able to bring all those things together into one model and one organization has been important. And you know, that was something that was recognized many years ago by the people working on this at the federal level, and making that requirement that community health center patients had to have access to all of those services. You can contract for those services, but most health centers like ours want to have those on site, because it really gets back to that question of trust. People, you know, really begin to trust the place, and they see the same people when they come in, the same providers, the same people at the front desk, and that makes a big difference. I think the other thing is the way that we're structured is we have a board of directors that is required to have over half of the members patients of the health center. So when we have board meetings, we are having people that might have had an appointment earlier that week, and people are very honest about, you know, what went well and areas that we could improve in. And so that board structure is also something that's baked into the way community health centers operate. The other thing we have is we have two patient advisory committees. One is a Spanish-speaking group, the other an English-speaking group. They've been in existence for over 8 years now. I thought when the pandemic hit that would probably fall apart, but it didn't. They met virtually throughout the course of the pandemic. You know, we get rides for people, we provide childcare, we serve dinner at their meetings, and we bring relevant operational issues to them. So they're making decisions about how our sliding fee structure is put together and scheduled. So they're doing important work for us as an organization. We also have a community advisory committee of about 50 people in our community that have supported us over the years, and we meet with them twice a year, talk about what we're up to, how we hope to grow, how things are going in general, and they provide their feedback to us as well. The last example I'll give, and going back to Saving Our Babies and ConnectRx, is that the way that we thought about this program as a collective is very different. I think a lot of times healthcare comes to people and says, this is what you should have, or this is what you should do. And we really listen to the community in a different way. And that concept of nothing about us without us was something that we paid attention to throughout this process and continue to, as Dr. Green mentioned, just with the structure of the Dane County Health Council.
And Dr. Levin, just because you mentioned it, can you share just a note about what ConnectRx is?
Yeah, so ConnectRx is I should have talked about that more, but it's the program that the group has put together so that women, when they come into clinics and are pregnant, get screened for the social determinants of health. So it goes back to some of the things that we talked about before. And there's some criteria for them to be able to enter the program that we talked about, where they can get community health center support and doula support ultimately. It's also a tool that allows the healthcare providers to see what kind of care has been done for patients and sort of coordinate the care across the community.
And I think that one of the cool things that I've learned about the ConnectRx piece of the work is, to Dr. Green's point, that what's good for Black folks is good for everyone. While this tool was originally created to specifically serve this coordination need around Black maternal health and the Black infant mortality in our community, it's a tool now that's just being used widely for folks to screen people who are coming into clinical environments on their social determinants of health, right? Yeah. Okay. All right, Amanda, I'm going to come to you now. All right, so question for you. So you shared a little bit about this as it relates to waivers and lieu of services, as far as kind of the core mechanisms through which Medicaid can do some innovation. So what challenges does our state Medicaid program currently face impacting its ability to be most effective in addressing health disparities and health equity in our state?
I'll try and keep that list short. We have a lot of strengths to build on, and I think to the point that the two of you have already raised, Michelle, Dr. Robinson, you've also raised this. The collaborations and partnerships that are happening are one of those key strengths. I think engagement is critical, and it will take all of us to be able to do better, and we need to do better. So grateful for the commitment. We've had some good successes recently that we can build on. I mentioned housing for children. This isn't Medicaid specific, but in Wisconsin, our Medicaid program also does our food share, or our SNAP program, so food for kids and families. And we were the first state. The governor really understands the criticality of these social supports for so many reasons, but we were ready when CMS and FNS, the federal government, gave the approval that we could provide more food for kids during the summer months when school was out, and Wisconsin was the first one to be able to support that. We want to be that ready as much as possible to amplify and support and send our money to do that good work. We talked a little bit about workforce already. There are a variety of ways we could continue to talk about the criticality of having people to care for each other. But I think two really actionable, immediate things that would help and are relevant here today. One is, I'm really proud of Wisconsin, happily a kid who grew up here and has spent nearly my whole life here. I'm shocked that we haven't been one of the majority of other states to provide 12 months of postpartum coverage through Medicaid. We're one of only 2 states that don't do that. And instead, we support our moms through 60 days after they give birth, our birthing individuals for only 60 days. And you know, it's at that time you've just done your follow-up visit and you are learning that you probably have postpartum depression, actually, and that is a primary driver of deaths among birthing individuals. So I'm shocked too, because it seems so clear to me that this is an easy answer. We've got 70 co-sponsors on this bill. Wisconsin is never one of the last people to the table, so it is past time. We need 12 months of coverage for our moms and their families. And then the other thing is it's time to finish Medicaid expansion. We did most of it already. We provide Medicaid coverage for individuals up to 100% of the federal poverty level. If we talk about one person instead of a family of three or the household of three, that's only $15,000 a year. And if we move and accept up to 138%, that same individual can make $5,000 more this year and still keep their Medicaid coverage. And in addition, Wisconsin gets another $1.6 billion and another $300 million year after year. And there's so many ways we could spend that money to address the variety of social problems we've talked about today, or a variety of other things that the state decides is the priority. So Medicaid expansion to me is like, we've already done most of the job. It's time to finish. This would impact 90,000 people in Wisconsin. This is very real, meaningful money for them to buy their own food, to pay their own rent, to buy the sneakers they need to help get some exercise. So maybe if I had two wishes, I would say postpartum and Medicaid expansion.
I got you an applause. Thank you for that. And I think one of the things I just want to reinforce in your comments, that you're talking about people who are working, right? We're talking about people who have jobs, who are just not well paid, and who still need health insurance. They need to be able to go to the doctor, whether or not they're ill, preventatives, and they need to be able to do that without either feeling like they're going to fall off a financial cliff or to delay treatment until things are, their outcomes are going to be much, much worse. And so that's a really important piece of this. So thank you for sharing that.
Thank you.
All right. Dr. Green, you were kind of nodding, and I don't want to put you on the spot, but I do also want to.
But you just did.
I did. I want to give you an opportunity to chime in on this kind of expansion, and particularly maybe the 12-month postpartum part.
I think it's important. I think whether it did anything or not, people deserve to have dignity in care, and people deserve to have health care. And the reality is, when we talk about, as someone who serves on maternal mortality review, I have that honor, and to be quite frank with you, the trauma and despair of doing that work. And what is frustrating to me is that there are things that we can do. And part of it means, one, making sure that people have health care, and they have health care without discrimination, and making sure that we're expanding care, particularly for people with substance use disorders, and not treating them as if they have a moral problem instead of a medical problem. So in our state, many of the things that we see in maternal mortality review are because of that, and making sure that Medicaid plays a role in making sure that there's care for the birthing parent and infant to get treatment together, making sure that people have care that is holistic and dignified without judgment, I think is critical for making sure that people have the best start at life, and also making sure that people have care, because so many problems crop up during pregnancy, especially cardiovascular disorders of pregnancy. I think those are really critically important. And finally, what I would say is, to the full expansion of Medicaid, actually everybody needs health care, but when we talk about the full expansion of Medicaid, if we're trying to address pregnancy-related issues, we are playing a fool's game if we just stop during pregnancy. Everybody needs health care. Everybody needs health care, because if we do not do that, then we will not be able to catch things and make sure that people have the choices that they want to be able to enact to have a healthy reproductive life, whether they choose to have children or not.
Before you put your mic down, can you share what the maternal mortality review team is?
Oh, I'm sorry, I should have explained that. The Maternal Mortality Review Team is a multidisciplinary team of clinicians, social workers, researchers like me, other folks in the community that gather together bi-monthly. We have an amazing nurse abstractor that does the heartbreaking work of going through when we find out that someone has died, either during pregnancy or up to a year after delivery. We review all of the cases to try to determine whether or not they are pregnancy associated, as in happening during pregnancy but not necessarily related to the pregnancy, or those deaths that are related to the pregnancy. When we talk about maternal mortality review, the only reason we know what happened in Georgia is because a maternal mortality review reviewed those cases and was able to determine that the 2 Black women that died because of restrictive abortion policies in Georgia, they were able to make those connections. So what we do is we review the cases, we look at not just we don't have, unlike at the federal level, we have police reports, we have prenatal care reports, we have sometimes interviews with the families. That allows us a more holistic way of being able to determine whether those cases are related to pregnancy, and more important, how we can prevent them from happening in the future so that families are not devastated.
And I believe you all release a report quarterly on sort of high-level findings and recommendations from the reviews, correct?
Yes, we were a little bit behind, but what you can do is go on the website for the Maternal Mortality Review, and you can see summaries of the meetings that we have every other month. And you can have high-level information on what we found. Obviously, these cases are very sensitive, so not individual information, but more general information. For example, when the Maternal Mortality Review team, before I got on there, saw that a number of people were, pregnant people were dying from COVID, they and other maternal mortality review teams released the alarm, sounded the alarm, so that that clinicians, health systems, social service systems could move into action so that we could prevent more deaths.
And Dr. Loving, I'm going to pull you in on this conversation and just ask you, what would 12-month postpartum coverage mean for the folks that are coming and receiving obstetrics care with the center?
Yeah. You know, the thing about the community health center is we wind up caring for people whether they have coverage or not. So, you know, one of the things that's happening right now with the Medicaid redetermination is there are some people dropping off of the Medicaid rolls. And Medicaid for us is really our financial lifeblood. That's our main payer, and that's the majority of the patients that we see. The more people with Medicaid that we see, the more uninsured people that we can take into our practice. So we would continue to care for, and we do continue to care for women when they fall off the Medicaid rolls, and you know, the care continues to be high quality care. But what it doesn't allow us to do is to grow when that happens. And I think that there's a misconception about FQHCs, community health centers, that we just take care of everybody who can't be seen in different settings. We take care of all the uninsured people out there. And that's unfortunately not the case. You know, my office is near our call center, and when I walk through the call center, every day I hear our call center staff saying, you know, we can't get you in for services right now. You're going to need to call back in a month and see if you can get in then. You know, if it's an urgent need, we do our best to get people in, but the need is not being met. And, you know, 20 years ago, we had about 3,000 patients, and today we have almost 33,000 patients. We've grown because we're trying to say yes as often as we can to people. And that's people that are birthing, and people that have a terrible toothache. It's people that have, severe depression that has returned. We want to be able to get those people in. And when you talk about the 90,000 people that would be covered by Medicaid, if we took the expansion money, that would make a huge difference for us and for them.
So in our last 5 minutes, I think I'll just ask a broad question and have each of you react to it. So we've had a conversation where we've talked about the context of health inequity. We've explored things that are happening, things that could happen, and some of the constraints that we're facing as a state to implement or operationalize some policy. So for each of you, can you share in maybe a minute, what do you see as being at stake for both our state and our nation if we do not find a way to accelerate both our investment and our collective responses to health investing, health preserving, and health repairing social and public policy? And I will start with Dr. Green, because I'm going to give you a moment to think. Dr. Green, you look like you're ready.
I look like I'm ready. Okay. You know, I'm going to turn that around because I choose hope. I choose hope. I believe in my adopted state. This is the second time I've lived in Wisconsin, and I was a patient at Access Health as a postdoc. You know, I believe that even though we are very different, that there is a common thread of humanity that joins us all. That even if some of the people in this room or none of the people in this room will ever go to a federally qualified health center, that many of you will not deal with some of the issues that we have up here. These may be your friends, these may be your loved ones, these may be people that you'll never see again, but I believe that we can, and I believe we will, because we know that investing in the people of Wisconsin is what is going to make us even greater. I truly believe that, and I also believe that we all deserve that flying car.
Let's get us the flying car. All right. Dr. Levin?
Yeah, I like the hope theme, so I'll continue with that. I think that, you know, for me, thinking about what we're doing with ConnectRx and saving our babies, you know, Dr. Robinson talked about the loss of potential that our healthcare system hasn't been able to solve over the years. And I think the effort that we're putting into this, what's been an intractable problem, and something that, you know, oftentimes is not even mentioned or people are aware of, and that is these you know, terrible birth disparities in our country. I feel like we're on the path to being able to get some answers to how to do this better for people. And, you know, that kind of collaboration and that hope is what gets me through. And I think we can make progress there.
Thank you, Dr. Loving. Great. And Amanda?
That was nice of you. I agree. I think this could go to a pretty sad imagining pretty quickly, and I choose not to. And we get to make that choice every day. And I refuse to live in a world where we don't take care of each other, where we don't understand and hold hands and link arms and wrap around and be there for each other. And I feel really grateful to be able to work at a place where I'm not the only person who feels that way and approaches work that way. I'm really encouraged that we have such great partners to be able to do that same work and lean in and build the community and the world we want to live in. And I agree. I believe we will get there. I believe we are all here, literally in this room, and carrying forward the work every day to do what is hard because it is right, and because not only does it benefit someone else, it is our shared benefit, and it's worth it. It's worth the work, and we can do hard things. Here we go.
We can do hard things, and I agree. I also believe in us, and I choose to believe that most folks are folks who also care for each other and who wants the best for each other. So let's end on that positive note. Please join me in a round of an applause for our panel. Thank you all so much. Thank you all to our audience as well for being engaged. And we hope you all learned something and took something of value from this. So with that said, this concludes this session.